Sandra Rogers. Today I'm going to be talking about disease-modifying therapies for 5Q spinal muscular atrophy. I think this topic has been covered in this meeting over the last 5 years, but the data is kind of evolving from year to year, and I think it's been at least 2 or 3 years since we've covered it. So Dr. Lakota and I thought it would still be a good topic to share at this time. Here's the CME code, and I'll provide that at the end as well. As far as disclosures go, I don't have any financial disclosures that are relevant to anything that I'm going to talk about in this talk. Some of the data that I'm going to present is from personal correspondence with one of the drug companies that hasn't been published yet in peer-reviewed journals, but for the most part, the data that I'm presenting is going to be from peer-reviewed journals, and I've indicated that on the slides when it's not. But basically, I'm going to be going through briefly the pathophysiology of spinal muscular atrophy due to deficiency of the survival motor neuron protein, and then provide an overview of the 3 main disease-modifying therapies available and the clinical trial data that has led to their use and FDA approval. I'm going to give what is available in terms of an update on current long-term outcomes from patients who were treated in the initial trials of these medications, and then talk a little bit about our experience of treating this disease at University of Louisville and Norton Children's Medical Group. So starting out, I'll briefly go over the pathogenesis of spinal muscular atrophy due to deficiency of the SMN protein. It is an autosomal recessive disorder that affects the lower motor neurons of the spinal cord, leading to motor neuron cell death, muscle atrophy, and skeletal muscle, respiratory, and bulbar weakness. In the past, prior to the discovery of the SMN gene and SMN protein, and prior to the availability of commercial genetic testing, the diagnosis was often made based on clinical grounds, along with EMG nerve conduction study and muscle biopsy. On muscle biopsy, you typically see areas of grouped atrophy of muscle fibers, indicated by this green arrow here in the bottom part of the figure, as well as other areas of muscle hypertrophy, which is very abnormal compared to a normal muscle where the muscle fiber size is relatively evenly distributed. In postmortem analysis of spinal cords of patients with SMA, similarly, you see atrophy and death of the motor neurons of the anterior horn cells. So you can see kind of the smaller atrophied nerve cell bodies compared to normal here. In terms of the clinical presentation, this was definitely understood and sort of stratified before the molecular genetics was discovered. And SMA has been sort of broken into 5 main types based on clinical features. And these types are stratified based on age at disease onset, greatest motor milestone achieved, and life expectancy, with type 0 being the most severe and type 4 being the least severe, with the best prognosis. Unfortunately, type 1 SMA, which is early onset and quite a severe form of the disease, is the most common and represents 50 to 60% of cases of spinal muscular atrophy. Overall, for an autosomal recessive condition, it's fairly common. SMA overall is present in 1 to 10,000 to 12,000 live births, and there's a carrier frequency of about 1 in 50. And so it is a disease that, while autosomal recessive and relatively rare, is something that as pediatric neurologists we would often see. And again, 50 to 60% of those cases were characterized by this early onset of disease within the first 6 months of life, patients never achieving the ability to sit, and a short life expectancy, with 92% of patients either dying or depending on permanent mechanical ventilation by the time they're 2 years old. In the 1990s, the region responsible for SMA was linked to chromosome 5q. And in 1995, the survival motor neuron, or SMN gene, was discovered. And it was discovered that there were two variations of this SMN gene, named SMN1 and SMN2, both present on the 5th chromosome. And these genes are quite similar. I'm going to talk a little bit about them in detail here because understanding the differences can help to understand a couple of the therapeutics that we use these days to treat SMA. So both of the genes contain 9 exons overall, 7 of which get transcribed into the kind of final protein product. They actually only differ by a total of 5 nucleotides in their whole sequence, but only 1 nucleotide within the coding sequence of the gene. And this difference within the coding sequence actually doesn't even change the amino acid that is eventually translated into protein. But what it does is it alters the collection of either pro-splicing or anti-splicing factors that accumulate around exon 7 of the gene. And so in SMN1, the nucleotide is a C, which allows for basically a splicing enhancer complex to assemble and allow for splicing out of the introns before and after exon 7, which ultimately leads to inclusion of exon 7 in the final mRNA, which gets translated into protein. So these figures here are the pre-mRNA. In the SMN2 gene, even though, again, this change to a T nucleotide doesn't actually alter what the amino acid sequence would be if exon 7 was included, it allows for the accumulation of anti-splicing factors to accumulate here around exon 7, and rather than splice out the introns, they actually splice out the entire exon 7, leading to an mRNA product that excludes the exon completely. This does translate into a protein product, but it's thought to be unstable and rapidly degraded and non-functional. About 90% of SMN protein that is produced from the SMN2 gene ends up with this pattern and ends up being non-functional. Probably about 10% does undergo the quote-unquote correct splicing pattern that would be needed to result in a full-length SMN protein. And so SMN2 does make a little bit of functional SMN protein, but not very much. Also interesting and relevant to the pathogenesis of SMA is the number of copies of SMN1 and SMN2 that an individual has. So everyone has, in the normal state, 2 copies of SMN1, but then there can be variable copies of SMN2. So what does the SMN protein do? We don't know 100%. There's obviously been a lot of research into this. It is ubiquitously expressed in somatic cells and is present in the cytoplasm and the nucleus. There are particularly high amounts of the SMN protein in the motor neurons of the spinal cord. And it does seem to play a role in proper splicing of pre-mRNA, not just for the SMN gene, but for other genes. And so it's possible that aberrant splicing plays a role in the pathogenesis of the disease. And then it also seems like it may play a role in the proper processing of beta-actin mRNA, which becomes relevant for motor neuron axon growth. But the bottom line is we don't really have a full understanding of what this protein does, other than, as its name suggests, it's crucial for motor neuron survival. So again, I mentioned that the number of copies of SMN2 gene is relevant for the pathophysiology of SMA. And increasing SMN2 copy number at least loosely relates to disease severity, with increasing SMN2 copy number correlating with less severe disease, later onset, and greater life expectancy. But this isn't a perfect correlation. So we can definitely see overlap in the phenotypes and SMN2 copy number. And it's really just more that a majority of patients in a given phenotypic category tend to have a certain SMN2 copy number. But it's not an absolute rule. In general, patients with type 1 SMA have 2 copies of SMN2. Patients with type 2 SMA have 3 copies, and patients with type 3 would have 4 copies. That's kind of how things generally stratify out. Prior to the last decade, there were several clinical trials that looked to see if any of these listed substances would make any difference in the outcomes in SMA. And the bottom line was that they didn't really, particularly in infantile onset severe SMA. But fortunately, once the molecular genetics was better understood, some smart people were able to figure out a way to use gene-targeted therapies to treat this disease and make a very significant difference, as I'll show you, in the outcomes of the patients. So these are the 3 main disease-modifying gene-targeted therapies that are now actually FDA approved and commercially available. And I'm going to focus in on each one of them today and, like I mentioned before, talk about the clinical trials and long-term data as we have it in terms of the efficacy of each one of these agents. Centerson was the first one to receive FDA approval, and it was approved in December of 2016 for patients of all ages with all types of SMA. And the way that it works, it's an antisense oligonucleotide, or ASO, that works at the level of the SMN2 gene pre-mRNA. And what it does is it binds to the post-exon 7 intronic sequence to alter the splicing to include exon 7 in the mRNA, which leads to translation of a full-length SMN protein. Because it's an ASO, one of the big downsides to this medication is that it has to be given intrathecally through repeated lumbar punctures. So ASOs don't cross the blood-brain barrier, and so giving through IV or oral methods wouldn't be possible. So the way that this medication is given is by 4 loading doses over the first 2 months of treatment, followed by maintenance dosing every 4 months indefinitely. And so that is kind of another downside, is that this medication has to be continued throughout the patient's life to have continued efficacy. In general, we do have to monitor some labs when we're treating patients with Centerson. It can cause thrombocytopenia. We monitor the coagulation profile because there can be some abnormalities there, and also with repeated lumbar punctures, we want to make sure that coagulation is working correctly. In general, with ASOs, there can be some impact on kidney function, and with Centerson specifically, in the clinical trials, there was an elevated urine protein detected. So we do monitor those things as well, but this really hasn't translated into anything clinically meaningful for any patients. And so it's something that we monitor, but typically it's not a huge issue and doesn't cause discontinuation of therapy. Practically, the main things that we run into that limit our ability to give this medication are that patients either get to an age or strength level where they need sedation to have the repeated lumbar punctures, which isn't the end of the world, but it's not the best thing to sedate a child, 3 times a year for the rest of their life. And then even patients who are being treated for their SMA will often develop scoliosis. And so that can be complicated to administer the medication in patients with severe scoliosis. Additionally, remember that I told you this medication was approved for all ages and all types of SMA, and so we've started it on some patients who already had severe progressive disease and a pretty significant curve in their back. Interventional radiology does help us out with this, but it's not necessarily ideal. But as I mentioned, from a medication standpoint, it's well tolerated, and most of the side effects and issues that we run into are related to the lumbar punctures. The Endear study was the clinical trial that led to the FDA approval of Centerson. It was published in 2017, and it was a randomized, double-blind, sham procedure-controlled phase 3 efficacy and safety study of the drug. Their primary endpoints, in addition to safety, were looking at motor milestone response and event-free survival of patients treated with Centerson compared to those who underwent the sham procedure. All patients in this study had genetically confirmed SMA with deletion or disruption of the SMN1 gene and 2 copies of SMN2, and they all had symptoms at the time of enrollment before 6 months of age. And so this puts them in definitively in the category of type 1 SMA. And 122 patients underwent randomization for this study, with 110 completing the study. What they found here was that patients did meet both of the primary endpoints of change in motor milestone score and improvement in event-free survival. These figures are showing the change in motor milestone response. So on the left-hand side of the screen, this represents, I think, 73 individual patients who were in the study. And it's showing you basically with the green bar what the change in the Heine-2 was over the study period. So the Heine-2 is a motor scale that we use to kind of quantify infants' motor skills at a given age. And so the larger the bar, the greater the change for the better in the Heine-2 throughout the study period. Those in blue bars were treated with Centerson. Those with gray bars are the control group. And so as you can see, there is definitely a positive response in the Centerson group in terms of their motor control or their motor skills. And then this graph on the right-hand side of the screen here is showing you kind of just the average of this data. And so the mean change when you take all the patients together in the Heine-2 with a significantly greater response in the treatment group compared to the control group, who basically had either stabilization or decline of their motor function. In terms of survival and event-free survival, there was also a positive impact of Centerson versus the control group. They defined event-free survival as either being alive without permanent ventilation or being alive with less than 16 hours of ventilation per day. And they found that the probability of event-free survival remained quite a bit higher in Centerson compared to control as time went on. And at the end of the study, 61% of patients in the treatment group were alive without use of permanent ventilation compared to 32% in the control group. So as I mentioned, this data was compelling, led to FDA approval of Centerson for all ages, but because this study was looking at only infants less than 7 months of age, they also wanted to study this drug in older children. And so that led to the Cherish Study. This was, again, a double-blind, sham-controlled phase 3 trial where some children received the study drug and some children underwent a sham procedure. These patients were aged 2 to 12 years of age with symptom onset after 6 months of life. And so these patients would be either type 2 or type 3 SMA. The average age of disease onset of patients in this trial was 10 to 11 months. And on average, patients had experienced disease for 39.3 months in the treatment group. Most of these patients had 3 copies of SMN2, but there were some with 2 copies and some patients with 4 copies of SMN2. The primary endpoint in this study was the mean change from baseline in the Hammersmith Functional Motor Scale Expanded, which again is another one of these motor scales that we follow in patients with spinal muscular atrophy and other neuromuscular diseases. And these patients underwent treatment for 15 months. And they did find that there was a positive response on the Hammersmith in patients who were treated. So the change from baseline in the mean Hammersmith score in the treatment group was 4 points compared to a decline of 1.9 points on average in the control group. And then they also looked specifically at how many patients achieved a change in their Hammersmith score of 3 points or greater, which had been previously deemed clinically meaningful. So, when we're looking at all of these scales, the numbers are great, but we want to understand, how big of a change is needed for that to actually make an impact on the patient's life. And it had previously been determined that a change of 3 or more points was enough for the patient to notice and for it to make a difference. And so 57% of patients in the treatment group had a change of 3 or more points compared to 26 in the control group. Another scale that they looked at as a secondary endpoint in this trial was the revised upper limb module. And the change in this was also greater in the treatment group versus control, so 4.2 versus 0.5. So these are all great, again, clinically meaningful. But when you actually look at, how many of these 120 something patients achieved a true new motor milestone, it's only one. And so there's only one patient who went from not being able to stand alone to being able to stand and walk by themselves. And so again, while there's improvement, this didn't allow all of these patients who had been symptomatic for 2 or 3 years at least to suddenly get up and walk. This figure is showing you in graph form the data that I kind of just went over. On the left-hand side, this is averaging all of the change from baseline of the Hammersmith scale in the treatment group versus the control group, as well as the revised upper limb module in the treatment group and control group, so quite a divergence in both of those. On the right-hand side of the screen, this is looking at the change in the Hammersmith for each individual patient in the group, plotted against their age and their disease duration. And basically what you see here is that there is a sort of clustering of a larger increase in the Hammersmith score in patients who started treatment when they were younger, and with a shorter disease duration at the time of initiation of treatment. So kind of underscoring that patients are going to do better the earlier that you treat them. Probably one of the most exciting studies that we've seen out of the groups studying nusinersen is the Nurture study. This is an ongoing study, so it's not complete yet, but they did publish some interim data in 2019 that was very encouraging. And this is an open label, single arm study to look at efficacy and safety in pre-symptomatic infants with SMA. So if the idea is that patients who are treated earlier do better, the thought is that if we treat patients before they develop clinical symptoms, that will lead to the best outcomes. And so these patients had either 2 or 3 copies of SMN2. 25 patients total were enrolled. And the first dose was given, again, when patients had a normal neurologic exam before they were 6 weeks old. And the primary endpoint here was event-free survival and freedom from any sort of respiratory intervention. So again, event-free survival is defined as being alive without the use of mechanical ventilation for more than 16 hours per day. And what they found at this data cutoff of November 19th was that 100% of these 25 patients were alive without permanent ventilation. 4 of the patients in the group had required some sort of respiratory intervention during an illness. for at least 6 hours per day. 2 of those had subsequently discontinued the respiratory support, but 2 patients were continuing to need respiratory support for more than 6 hours per day, but again, less than 16 hours per day. And then 100% of these patients were sitting without support, 92% were walking with assistance, and 88% were walking independently at the time of the data cutoff. So again, remember, 15 of these patients had 2 copies of SMN2, which would typically predict a type 1 SMA phenotype. And those patients historically would never sit without support and would require permanent mechanical ventilation for survival at 2 years of age. And so this, so far is pretty remarkable data. Because this has been FDA approved for patients of all ages, there have also been a few groups who have kind of looked observationally out in the real world, how are adults doing who are, and older children doing who are treated with nusinersen kind of in the clinical setting. Is this something that we should be doing for these patients, even though we know it works better when treatment is started younger? Probably the best study that's out there is an observational cohort study out of Germany that was published in 2020, looking at almost 140 patients aged 16 to 65 years. And they basically just followed the patients over time up to 14 months and measured their Hammersmith scale. And they found that there was an increase in the average Hammersmith over time, up to, at the end of the study, reaching that increase of 3 that we had deemed to be clinically meaningful. And so a clinically meaningful increase was seen by the end of the study in 40% of patients. Again, these patients who were type 2 SMA, not able to walk, weren't getting up and walking around, but clinically meaningful improvement and well tolerated from a safety and adverse event standpoint. So that is the data on nusinersen. The next treatment that I'm going to talk about is Simnogine abiparvovec. This was FDA approved in May 2019 for all types of SMA, but it was only approved for patients less than 2 years old. And this is a true gene replacement therapy. So this is an adeno-associated virus serotype 9 containing a double-stranded complementary SMN1 gene, the full copy of the gene, that gets introduced into the cells and is under the control of a hybrid CMV enhancer chicken beta promoter that leads to sort of continuous transcription and translation of this gene. Because it is not an ASO, not like nusinersen, and it's an AAV9 virus, it can be given intravenously because it crosses the blood-brain barrier. And it's actually just a one-time IV dose, which in a lot of ways is really nice and kind of simplifies things for the patients. It does have a little bit more in terms of its side effect profile and sort of screening labs and monitoring that's required to give this treatment, though. So before patients can be treated with Simnogine abiparvovec, they have to have normal hepatic function, including coagulation profile, normal platelet count, normal troponin concentration, and this is the one that really gets us, AAV9 antibody titers that are within what has been deemed to be kind of the safe and normal range. And so that, this is a virus that is in the world, and so some patients have had exposure to it. And if they have titers that are higher than acceptable, then we're not able to treat patients with this medication. Because a lot of times we're looking at newborns, the antibodies that we detect in their blood are likely from the parent, and so we can often just repeat the level a few times and it will come down, but sometimes these antibodies have precluded treatment with this drug. We monitor hepatic function because that is one of the most common serious adverse events that can happen with this drug is hepatotoxicity. It seems to be attenuated with systemic prednisolone, and so we put all patients who are going to receive this treatment on 1 mg per kg of prednisolone for at least a month around the time of treatment with a subsequent 1-month taper. And then we monitor their labs very frequently for at least the first 3 months post-infusion, and sort of titrate the steroid treatment based on what their labs are doing. So the clinical trial data that led to Simnogine abiparvovec's approval started with the START trial. So this was a phase 1 dose-finding efficacy and safety study. This included patients similar to the first trial of Centerson that I presented, the Endear Study, who were symptomatic. So patients already had confirmed SMA, they had symptoms before 6 months of age, and these patients all had 2 copies of SMN2. So these patients were squarely kind of in that type 1 SMA phenotype. They treated 3 patients with a low dose of the virus and 12 patients with a high dose. And they looked at safety with secondary and exploratory endpoints of event-free survival and change in motor function. From a safety standpoint, like I mentioned, the most common serious adverse event was elevation of liver enzymes. This happened to the level where it was qualified as a serious adverse event in 2 patients, but the elevations came down with continued steroid treatment. And then in 2 patients, there were sustained elevations of liver enzymes that required continued steroid treatment, but didn't reach high enough levels to where it qualified as a serious adverse event. Some other patients can have some vomiting, but those were the main clinically relevant adverse events seen in this trial that were thought to be actually due to the study drug. In terms of event-free survival, this graph here is showing you each patient that was enrolled in the study. So the top part in blue, these blue hues, are the 3 patients who received a low dose of the virus, and the bottom part is the 12 patients who received the high dose. And this is event-free survival. So as time goes on, these are patients who are still alive without permanent ventilation, defined by ventilation for 16 hours or more per day. And all of these patients achieved that endpoint. So at the ones with the stars had reached the end of the study at the time of publication. These other ones were still being followed, but they were all alive without permanent ventilation, and they had all crossed this green line here, which is 20 months of age, which is a big milestone in SMA because that's the point at which, based on historical controls, 92% of patients would either be dead or requiring permanent mechanical ventilation. So all of these patients did better than what we would expect based on historical controls. In terms of the motor function, the motor scale that they used in this study was the CHOP and TEND. And again, these 2 graphs are showing you the low dose cohort here on the left and the high dose cohort here on the right. The low dose cohort, definitely met that endpoint of event-free survival, but did not really do awesome in terms of change in motor function over time. So they, pretty much kind of remained stagnant and never reached this CHOP and TEND score of 40. So this CHOP and TEND score of 40 is relevant because this is the number that historical controls of SMA type 1 patients never reach. So some patients would have a score of 40, but they never get above that. And these patients in the low dose cohort kind of followed that trend. Those in the high dose cohort, though, all but one crossed this CHOP and TEND score of 40, and some actually even maxed out their CHOP and TEND score. So did quite well in terms of their new motor skills acquired. And again, kind of similar to what we saw in some of the Centerson data, patients who were treated early tended to have this kind of more dramatic uptick in their motor scale. And then also patients who started out with a relatively high CHOP and TEND score tended to do better. But because all of these patients crossed this number 40, this is definitely not what we would have expected based on the natural history of SMA type 1. In terms of specific motor milestone achievement, in the 12 patients who received a high dose of the virus, 75% were able to roll from back to side, 92% were able to sit without support for 5 seconds, and 75% for more than 30 seconds. 17% or 2 patients could stand alone and walk alone. So again, not consistent with the history of type 1 SMA. This was, again, the first trial that was done, and so this is the trial that we have the longest long-term follow-up data for. And this long-term follow-up, or LTFU, study published some interim results in May of last year. So they had 13 of the original 15 patients enroll in the long-term follow-up study, 10 of 12 in the high dose, and 3 out of 3 in the low dose cohort. And June 2020 was the 5-year cutoff in terms of their data. And what they found was there was no new serious adverse events thought to be related to treatment. So, there had been some concern that this treatment could lead to increased risk for malignancies, long-term hepatotoxicity. At least at 5 years, they hadn't seen that. And then they found that, again, 100% of the patients in the high-dose cohort were alive without permanent mechanical ventilation. 100% in the low-dose cohort were still alive, but one had started to require permanent mechanical ventilation. But there were no patients even with a new requirement for respiratory support. So no one even needing, extra support at night or for less than that 16-hour time period per day. And then in terms of new motor milestones achieved and maintenance of milestones that had been achieved in the initial START study, all patients who had achieved a certain milestone, so sitting, standing with support, walking, they all maintained their milestones without starting a new treatment. And so the efficacy was sustained over 5 years. And then 2 patients who previously were not standing with assistance started standing with assistance without starting a second medication. And so that's these 2 patients here. The SPRINT study is the pre-symptomatic treatment trial for Simnogine abiparvovec. So similar to Centerson, we wanted to look at, how patients obviously did better than historical controls if they received treatment after symptom onset. How would they do if we treat them early before symptoms developed? And so that led to the SPRINT trial. So this is ongoing, open label trial of pre-symptomatic patients, and they enrolled similar to Nurture. They enrolled patients with 2 or 3 copies of SMN2. They have 29 patients total in this cohort with with 14 patients with 2 copies and 15 patients with 3 copies of SMN2. And they treated these patients early. So both cohorts, average age of treatment was before 30 days of life. So at about 3 or 4 weeks of life, these patients received treatment. And they've been following patients in both cohorts for an average of at least 14 months. And what they found is that 100% of these patients in both cohorts are alive without permanent ventilation and without nutritional support, so continuing to eat by mouth. In the patients with 2 copies of SMN2, 79% are sitting without assistance, and 36% are walking without assistance. Again, these are the patients who would have been predicted to have type 1 SMA. And they're walking within, 36% of them are walking within a normal time frame for walking. And a large percentage of the patients who have not achieved these milestones yet are still within the WHO age-appropriate range for achieving that milestone. And so they may still achieve the milestone within a normal time frame. The study hasn't been going on long enough yet. In terms of the patients with 3 copies of SMN2, all of them are sitting without assistance. 80% are standing with assistance and 53% standing without assistance, and then 40% are walking without assistance. And then all of these patients for each of these milestones who have not achieved the given milestone are still within the age-appropriate window, and so still may meet the milestone on time. They've been tracking the Bayley, the gross motor subset score of the Bayley for these patients. And this is showing graphically the increase in the Bayley scores over time for each individual patient in the 2 different cohorts. So 2 copies of SMN2 on the left and 3 copies on the right. And they're showing this compared to the range as defined by the WHO of normal milestone achievement for unaffected children. So the gray sort of bars here are when you would expect normal, healthy children to achieve different milestones. And you can see particularly in patients with 3 copies of SMN2, these patients are essentially meeting milestones on time. And an impressive number of patients with 2 copies of SMN2 are meeting milestones on time as well. The last treatment that I'm going to talk about today is ristoplan. So this was the most recent disease-modifying therapy that was approved for SMA. This was approved for all forms of SMA, but because we already had 2 treatments that were known to be beneficial in pre-symptomatic SMA patients, it has not yet been approved for newborns. So it's only approved for patients aged 2 months and greater. It's a similar mechanism to nusinersen. So rather than reintroducing a normal survival motor neuron gene to the system, it actually works at the level of the pre-mRNA splicing to promote splicing and inclusion of that critical exon 7 that typically gets spliced out in the SMN2 gene processing. It has slightly different binding sites to nusinersen, but seems to sort of promote splicing in a similar manner. And because it's a different molecule, it's not an ASO, it actually does cross the blood-brain barrier and can be given orally. It does require indefinite use, so it's a daily oral liquid that patients take basically for the rest of their life. There's no ongoing lab monitoring. It's a lot easier to start than either of the other 2 treatments. The most common side effects are diarrhea, rash, and fever. There is some concern based on preclinical data that it could be teratogenic, so it's not recommended for use in pregnancy. And then there's also concern that it can decrease sperm counts in males. And so it's sort of recommended to at least talk about sperm banking with male patients before starting the treatment. The data that led to the FDA approval of ristoplan was from the Firefish study. This was a 2-part open label trial of 21 infants who were symptomatic with SMA, who were between age 2 to 7 months. And this was really a safety kind of pharmacokinetics, pharmacodynamic study. And post hoc, they looked at event-free survival and ability to sit without support, but those were not kind of the pre-specified clinical trial outcomes. And so that part 2 is still coming, and we kind of have to take their efficacy data with a little bit of a grain of salt here. The median age of enrollment of these patients was 6.7 months, so slightly older cohort, but still, similar to the symptomatic infant treatment trials for nusinersen and onasemnogene abeparvovec. 4 patients received a low dose of ristoplan and 17 patients received a high dose. They published their data with a data cutoff of February of 2019, at which point the median duration of treatment was 14.8 months. And 81% of patients at this point were alive without permanent ventilation at 28 months of age. 41% of patients in the high dose cohort were sitting without support for more than 5 seconds. And then 52% of patients overall, so low dose or high dose cohort, had reached that CHOP INTEND score of greater than 40, which again would not be expected in patients with type 1 SMA. And then again, since this was, predominantly a safety study, there were no serious adverse events that occurred that were thought to be treatment related. So part 2, which is going to be kind of their more robust data in terms of efficacy, is still coming. The Sunfish trial is a separate trial looking at older patients with SMA, so age 2 to 25 years. This was a placebo-controlled trial of 180 patients with, and based on their age and disease severity, they were classified as having type 2 or type 3 SMA. And they're basically looking at the MFM32, which is another one of these motor scales. And they did show, kind of an improvement in the treatment group compared to control. But this is still sort of preliminary data and hasn't been published and peer-reviewed yet. They also looked at the revised upper limb module in Sunfish, which showed an increase with ristoplan compared to the placebo group. Jewelfish is an interesting study that I think is helpful. Again, this is kind of pre-publication data, but this is an open label study of adults and children with SMA who had received some sort of treatment prior to starting ristoplan. And so the majority of these patients had either received Simnogine, abiparvovec, or Centerson. And what everybody kind of wants is efficacy data. Did this improve things more than it would have if they wouldn't have treated it? I don't think we're going to have that. This is predominantly a safety and pharmacokinetic study. But what the interim data that the company has shared so far is that it does seem to be safe. And just from a clinical standpoint, so that those of us taking care of older patients with SMA can know, there was a large age range of patients enrolled in this study, so 1 to 60 years. Several were previously treated with Centerson, several previously treated with Simnogine, abiparvovec. The majority of patients were type 2 SMA, but type 1 and type 3 was represented. And again, no drug-related adverse events leading to withdrawal, and the overall adverse event profile similar to treatment-naive patients. What people are really excited about with ristoplan, though, and what will be very interesting, is their pre-symptomatic treatment trial. So this is Rainbowfish, and this is ongoing, looking at patients less than 6 weeks of age who have a normal neurologic exam, who have been diagnosed with SMA. They're wanting to enroll 25 patients. They have 12 patients currently enrolled that have been treated for a median of 7.4 months. 5 of these patients have 2 copies of SMN2 and 5 patients have 3, 1 patient with more than 4 copies, and 1 patient with an atypical copy number. I have never seen that before, but that is apparently what they have. And so of the 12 patients, 5 of them have been treated for at least 12 months. And they do have some data on how those patients are doing with their motor skills. So again, this is unpublished, unpeer-reviewed, but this is what the drug company has shared. And so each of these rows here shows all 5 of these patients, so the ones that have been treated for at least 12 months. 2 of the patients in the dark blue have 2 copies of SMN2, and then 3 patients in the lighter blue have 3 copies. And they are all sitting without support, with 3 of them achieving that milestone within the normal age-appropriate window. All 5 of them are crawling. All of them achieved that milestone within the age-appropriate window. 4 of 5 are standing without assistance, standing without assistance. And the patient who is not standing is still within the age-appropriate window for potentially achieving that milestone, with the same findings for walking independently. So 4 of 5 are walking, with 1 still within the age-appropriate window at the time of the data cutoff. So encouraging, and definitely will be interesting if it pans out that this medication works as well as the other 2 for the pre-symptomatic patients. It'll really give patients a lot of options in terms of what treatment they want to pick for their SMA. So the compelling evidence that I've shown that treating patients pre-symptomatically is good led to widespread newborn screening for SMA. The first state to add SMA to its newborn screen was Missouri in July of 2017, and Kentucky added it to the newborn screen in August of 2019. Currently, it's on the newborn screen in 38 states, which is great, but also kind of crazy that there are even any states that don't have it on the newborn screen. I think they'll all get there eventually. Um, but this is typically how we meet these patients these days, is that we get a phone call within the first week of life for these patients that their newborn screen is positive for SMA. And, we make contact with the family, explain what that might mean. And then we do need to send confirmatory genetic testing and talk about potential treatment options for them. Dr. Lakodia and Dr. Thaman have actually been sort of tracking this data, the patients who have been identified on the Kentucky newborn screen over the last couple of years since it was implemented. We've had 11 patients who were first identified on newborn screen and then confirmed with confirmatory genetic testing to have SMA between August 2019 and October 2021. In general, the newborn screen resulted between 2 and 13 days of life. I would say over the last year and a half since I've been here, for the most part, the results are coming back within the first week of life. And then we often offer the patients a office visit the next day or within 2 days for them to come in and get their confirmatory testing drawn and sent off. And we're typically able to get that turned around once it's sent off within 2 or 3 days. And so sometimes there can be a little bit of a delay, but most of the time that's just related to actually getting the patient in, getting the blood drawn, things like that. 81% of the patients that we've taken care of from Kentucky have pursued treatment, 2 with nusinersen and 7 with onisimnogine abiparvovec. And the time to first treatment has ranged from 16 to 331 days. Again, this sometimes will largely depend on the SMN2 copy number. So if there are 4 copies of SMN2, we typically don't treat those patients as quickly, with a median of 48 days of life for treatment. So just in the past couple of months, we had a new patient who wasn't included in this cohort, though, who was identified on newborn screen and had 2 copies of SMN2, so wanted to get her treated as quickly as possible, and were able to get her treated at 13 days of life. And so, we've gotten pretty good at streamlining this process and getting patients treatment quickly if that's what the family desires and that's what's appropriate given the clinical scenario. We have treated more patients than 11 who have been identified on the Indiana newborn screen, but we've really been tracking the Kentucky data. So that is all that I had to share today. Thank you for your attention. I'm happy to take any questions if there are any.
Thank you, Amanda, for your comprehensive presentation. This is Dr. Friedland. Could you
Thanks.
comment on the financial aspects of this therapy?
Yeah, absolutely. So the big ticket one that makes everybody's eyes pop is that the cost of onisimnogine abiparvovec, just the drug, is $2.1 million. So that's the price that the drug company has set. For nusinersen, it is, I believe, somewhere around $150,000 per dose. And so over the course of a lifetime, one would still get to that couple of million dollar amount. For ristoplan, they've set the dose at they've set the price to where the annual cost is just slightly less than nusinersen, basically. And so they've kind of undercut them a little bit, but it's pretty close to where over the course of a lifetime, you would be looking at probably millions of dollars in terms of cost for treatment. We don't talk a whole lot about that with our patients when we're talking about, which treatment to pick. We, fortunately for me, since I've actually only been doing this kind of on my own for a year and a half, I've had a lot more success and a lot less headache than I think the people who were navigating this process when these drugs were first FDA approved had to go through. But actually, a lot of insurance companies have policies for these drugs now. Essentially, we don't have any issues getting approval for patients who have 2 copies of SMN2. So most insurance companies basically have a policy statement that if you have 2 copies of SMN2, they're going to pay for the drug. And if they have higher copy numbers, we do sometimes have to fight with them. But we typically are able to get treatment approved if we feel that it's indicated and if it's what the family wants. And we feel that it's certainly worth it for the patients and families, but it is interesting.
What about children without insurance?
Yeah, so I have not specifically run into that. The drug companies, I think, would probably work with us, or we would potentially have them, get the patient onto like a Medicaid plan as soon as possible. I think we would probably typically be able to do that if we needed to. But I have not run into that specifically. We have had physicians in other countries actually reach out to our nurse navigator saying, my baby has SMA, our country doesn't have insurance or have anything that pays for these drugs. Is there anything that you can do? And it sounds like some centers in the country will actually, bring patients over and work with the drug companies to provide treatment. But unfortunately, yes, it's definitely not accessible to every patient in the world who needs it.
A comment. Thank you. My comment is that these drugs were not developed from nothing by the drug company. They were developed by academic investigators around the world, funded by NIH and other government agencies, and then the drug company took over. So it has to be asked whether it's ethical or proper for them to be making such enormous profit as if they did all the work themselves, when actually most of it was done with publicly funded research.
Yeah, I agree. I mean, I think that's a great ethical question. Yeah, I unfortunately, I think more this is the way that things are going to go as public funding for research continues to, be at jeopardy. But it's something that is a problem.
Thank you. Finally, the other point, which is very exciting, is that this kind of therapeutic approach is going to be exploited or experimented also in neurodegenerative diseases, Alzheimer's, Parkinson's, Huntington's, ALS. There will also be various genetically modifications that are being explored, and it's very exciting to see the success with SMA.
Yeah, agreed. Agreed. But I do agree with you. It's really going to be a lot of it is the drug companies kind of driving some of those. And so I think that it's likely that we're going to see continued prices like this. Crazy.
Thank you.
Yep. Thank you guys. Everybody have a good day.